right. Good morning, everyone, and welcome to our Red Chuck's Healthy Heart Luncheon, hosted by Bates Community Development Corporation. I am Nation Treyview, the Executive Director of Bates Community Development Corporation. We're located in Louisville, Kentucky, in a small niche community called Smoketown, which is the first African American community in Louisville, Kentucky. We do a lot of programming services around health and healthy lifestyles, as well as youth programs and our food and nutritional programs is what we do most of. Right now, we're doing a lot of programming around food and nutrition because we're in a food desert. And so it's very important for us to do those type of programs right now. So we have a 4 hour of great, amazing content and information that's going to be brought to you. And right now, I'm going to introduce the board chair, Dr. F. Bruce Williams of the Bates Community Development Corporation. And I'm going to introduce him, and then I'm going to let him speak a moment in regards to healthy hearts within our community. Dr. Williams.
All right. Let me just, before I make any comments, let me encourage those who don't have to mute their speaker. We can hear some noise in the background. It may be because somebody's speaker is not muted. So if you would, unless you're speaking or asking a question, make sure you mute your speaker. First of all, I'm just really excited about being able to gather here around the subject matter of health. Nation, who's again our Community Development Corporation Director, has spoken about one of our missions as a Community Development Corporation is health. Now, I happen to pastor a church that helped start this CDC. And one of the reasons why we did it is because our philosophy of ministry is more than just getting people to heaven when they die. But we believe that God wants people whole. So my psyche, I knew my mind, body, and spirit, diseased body, diseased minds, uneased soul. God wants to minister to the whole person. And so that is the philosophical ministry approach that we have to wholeness. We know that, especially for the African-American community, the issue of health, there's been a great deal of debate, first of all, in the country about how health services ought to be parceled out to the body politic, and that's a whole nother subject matter. But one thing is for certain when it comes to the African-American community, we have been disproportionately affected. It's the neglect of the community, lack of access to healthcare, and then knowledge about healthcare as well, historical incidences and relationship between the African-American community and healthcare services and industry has been suspect and lacking. And so there's a great deal of apprehension in the African-American community, even insofar as it's been highlighted with regard to this vaccine that's been going out and trying to get African-Americans to take the vaccine, and the reminder that healthcare and health are an important factor in the African-American community. So we're really excited about being able to address this issue and have the kind, quality, and caliber of guests that we have here, the knowledge they'll be sharing with those of you who are here, and also really excited about fielding some of the questions that will probably come from those who are viewing this and to be able to answer them, and then all of the spinoffs that perhaps will come as a consequence of this being over. I've been in the Smoketown community that Nation mentioned. I'm not from Louisville, I'm from Florida, but I've been here for a while, since '82. And I've spent all of my adult life serving in the Smoketown community and emphasizing this issue of health, whether it be, like I said, healthcare or information about health or access to healthy foods, et cetera. I've been pastoring for 35 years. Now, I know that's hard to believe because I look 36, but I've been doing this for 35 years, and we've seen some great victories, but we still have some great challenges to go, which is one of the reasons why we're so excited about bringing this to you. And we hope that you will really latch on to this pay attention, ask questions, and be able to maximize the moment and take advantage of this situation. So thank you. There's a lot more I could say, but I'm more interested in hearing about from our guests. So thank you, Nation, for giving me a chance to comment. Listen, if you want to, and I want to take this opportunity, one last thing, just as a commercial, if you want to know more about the Bates Community Development Corporation, you can always look online, go online, look at our social media platforms, or just call and ask for Nation Tribute, and our staff and volunteers would be helpful. We'll be excited about helping you in any way, shape, or form that we can. One, I lied. It's just like a Black Baptist preacher. Just one last thing, and whenever we say we finish, that's a lie. Just one last thing, though. I do want to take the opportunity to commend the CDC for its service in the community since the quarantine, since March. A lot of things shut down. The one thing that didn't shut down was the Community Development Corporation, and Nation volunteers and staff have put themselves at risk to serve the community, because one of our priorities is the health of the community, whether it's feeding, giving access to healthcare, et cetera. So I do want to take the opportunity to publicly commend Nation volunteer staff of the CDC, of Bates Community Development Corporation, for all of the great work that they have been doing and that they continue to do in the community. Now, I really am finished now. Thank you so much.
Thank you so much, Pastor, and I appreciate that, and I'm sure my team appreciates that. We definitely are committed to the cause, and one of the causes in our community is being able to help provide resources and being able to give our community what our community is lacking, and our community is lacking a lot. So we every day we go in with our man on the mission to get the work done. So thank you so much for that. Now I'm going to introduce to you all Cynthia Benedict. I call her Cindy. And Cindy is the Director of Equity, Inclusion, and Belonging for Norton's Healthcare. This is almost like the perfect position for her, because before this position, Cindy has always been the one in the community who cared about the community. She's from the community. She played in our community. She grew up in the community, and she's been committed to the community. So it's nothing new for her to hold that title with Norton's Healthcare, because Cindy has always cared deeply about the least of these in the community. So Cindy, we appreciate the work you do in the community and the work you're doing through Norton's Healthcare. And we're going to turn it over to you.
Thank you. Thank you very much. Thank you. I am so pleased to be on this call. Happy to be a member of Bates Memorial, and super duper happy to always give back to our community in any form or format that God has allowed me to do so. In this format today, however, I will be introducing two of our physicians that work for Norton Healthcare that will be speaking on some much needed subjects for the African American community. So today I'll be introducing Dr. Stephen Patton and Dr. Kelly McCants, but we'll start with Dr. Patton. And Dr. Patton earned a bachelor's degree in biology with a minor in chemistry from Kentucky State University right here in Kentucky, and a medical degree from the University of Pikeville, Kentucky, College of Osteopathic Medicine. Dr. Patton completed his family medicine residency at Community West Hospital in Indianapolis, Indiana. And Dr. Patton is board certified in family medicine and is a member of the American Osteopathic Association and the Sigma Sigma Phi and Osteopathic Honors Fraternity. In his role here at Norton Healthcare, he serves as the primary care physician for the Preston Highway Office, and he was recently named the medical director for community outreach. In this role, he participates in educational health programs and events with a focus on addressing health equity in underserved areas. Dr. Patton collaborates with the Institute for Health Equity, which is also a part of Norton Healthcare, to strengthen community relations and access to care in an effort to improve health equity statistics. A native of Chicago, Illinois, Dr. Patton enjoys reading, learning different styles of martial arts, and is involved in community activities. Please help me in welcoming Dr. Patton as he discusses COVID-19 in the African American community.
Thank you so much, Cindy, for the introduction. And Dr. Patton, just let me interject real quick. We're gonna, for those who might have question and answers, questions for, as it relates to Dr. Patton, please, we have a chat we have a chat. If you look down, or a Q&A, you should see a Q&A, and put your questions inside of the Q&A if you have any questions as he's talking or something comes to mind, as well as take notes too for yourself. It's going to be some really great information that he's going to be able to share with us that we need to hear. So if you would do that for us, I am going to be the moderator, so I'm going to be jumping back and forth. So this is one of my topics, and I really needed this whole session just for myself around this whole COVID-19. Dr. Patton, as Pastor shared with you, Bates CDC, we have been open nonstop, probably working even more hours since COVID, because one of the programmings that we do is around health and nutrition. So, and we're in a food desert, so we had to prepare healthy meals ourselves, and then we provide fresh, healthy hot meals on a weekly basis to the community for those who are in need, or those who, you know, who live close by. We have people who actually was coming all over our community just to eat a fresh, healthy meal because they lost jobs, they lost income, you know, and a lot of other things were happening within their homes and their community. And it was a time when they were in need. So we was there to help fulfill that need. In doing that, one of the things that came always was spiritual. Oh, wow, I hope we don't catch, you know, COVID, because we still open, we're still operating. And there wasn't a talk about a vaccine then. And even if so, I probably wouldn't have entertained it back then anyway. So one of the questions I have for you is, what effects do you think the COVID-19 had on the Black community? Can you elaborate on that, please?
Yes, I can. I appreciate you all having me today. It's truly an honor. As far as the effects on the Black community, the virus has been detrimental across the US, across the world. And when we talk about the Black community and how it's been more disproportionate to our society, we have to look at it in this way. Initially, when we're looking at the numbers and statistics, African Americans make about 13% of the US population. While we were looking at that, we were looking at those who were being affected the most and the mortality or death rates that were occurring. And earlier on, it was about 20%. So something doesn't add up there. You make up 13% of the population, but 20% of that group is dying and suffering some serious illness. So it kind of makes you wonder, or it kind of highlights some things that what makes this possible. And that kind of brings me to the different social determinants which kind of affect that, because the virus feeds on obesity, diabetes, heart disease. So that also makes you say, the Black community, guess what we're higher in? Obesity, diabetes, heart disease, right? So we wonder, why is that the case? So you see, it kind of lingers on, and that's the reason behind that is because of these social determinants, like you were always saying, this food scarcity, deserts. Do we have access to get to those healthy meals? Are we in neighborhoods where we feel comfortable, where we can exercise and maintain that weight loss? Do we have access to care in general? And do we have insurance? And do we even feel comfortable do we feel like our needs are going to be addressed if we do go to someone? So a lot of times people don't even have a primary care doctor, they're going to the ER. But all these variables play a fact on why the COVID-19 virus, SARS-CoV-2, plays such a detrimental role to the African-American population.
That's good. Because I was always, you know, kind of wondering about the percentage you gave really hit when you say those two percentages. I'm like, yes, you know what, that makes a lot of sense. So thank you for sharing the data. That's so important. Had another question, and one of those, I'm gonna be very open and candid. I had a lot of mistrust, you know, in the beginning with this whole COVID thing, period. So one of my questions, what do you believe, why do you believe there is mistrust in the Black community regarding medical professionals? Can you elaborate on that, please?
Yes. First off, I want to say that it's understandable. And I think we need to acknowledge that in the medical field or just in general as America, that there has been a lot of mistrust, and there's a good reasoning behind that mistrust. I know a lot of people touch on the Tuskegee syphilis experiment per se. They were experiments testing the pain threshold, like they were giving people pain medicine. A lot of studies were done without informed consent, meaning they were watching us and we didn't know that we were being tested on. Particularly, we'll go back to the Tuskegee experiment because that's a little more well known, and that was going on from 1932 to 1972, where they were just watching people and the effects of syphilis head on in an individual without providing the cure, even when one was available. And if we think about 1972, my grandmother could still be around to witness that and remember that. And I feel like in the Black culture, a lot of our wisdom was always word of mouth. Even through the times of slavery, it was more word of mouth where we learned certain behaviors, what to stay away from, what to do. So even that carries on to the current generation. We get a lot of information from our elders and our parents. And a lot of times we don't question. We just say, they said, do this. This is how I'm going to do it, right? So when they start to hear, oh, vaccines, we've been down that road before. We don't trust. We don't feel like we have enough representation, because someone's going to feel more comfortable, honestly, with someone has an image, someone that's looking like you. And there has been some studies that's untold bias. People don't even know that they have these biases that has shown to affect healthcare in general. So I completely understand why we would have this mistrust, but it's time to have that conversation. It's time to acknowledge it. But at the same time, it's time that we understand that there are health ethic committees now. A lot has changed, and a lot of laws have been put in place to protect us now. And I want everyone to understand that there are providers that's fighting for you. I mean, even Kazmikia Corbett, who she helped create the Moderna. She was a major role model. That's African American, right? We're out here now, and we're also advocating for the health and safety too. But like I said, I understand why there is mistrust.
That's good. So I'm gonna be candid with you again as we talk about the vaccine. I haven't had a chance to get the vaccine yet, but one of the reasons why I'm going to get the vaccine is because I'm not really thinking about nation. I'm thinking about my loved ones and people in the community that I'm around. So I'm getting it for really everyone else. What would you say? What are some of the concerns about the vaccine that maybe you have heard?
Yes, a great question. There's a lot of concerns. I know I'm going to address a couple here. One was, how was this vaccine made so fast? I mean, I think that's the big concern there. Messenger RNA technology has been around. I know they were initially using it for cancer cells, but that technology has been around. They just applied it to a vaccine. And then we all know that vaccines have been around. So we kind of understand the gist of how the process works. So it's not necessarily new technology, but a new application for existing technology to be put in place. The other thing to what made the process move so quickly is it's a pandemic. It was affecting the world. And scientists from around the world got together and was able to communicate and share their data. Governments from around the world was able to communicate, and a lot of that red tape was been able to be cut or reduced, which didn't affect the safety of the vaccines, but a lot of procedures were able to happen a little quicker. And for example, when the virus was obtained from Wuhan, China, they were able to find out what's causing this disease. They looked at the virus and they said, this is how the virus works. This is what the virus is made of. Okay, So now we understand the enemy. And guess what they did? They went and shared that with us. So we didn't have to retrace the steps of what's the virus is or how is it attacking through the spike protein. We already knew that. So then we knew we had to find something to attack the spike protein so it couldn't replicate and cause that illness. So that's already a great head start. And then as they did the research, it wasn't well, we have to wait 5 months before the FDA approves it, because that research was put on top of the pile, because there's always new ideas coming out, and that's another time-consuming thing. That research was put on top of the pile, so it allowed the time to get more compressed, but still under a safety net. And then the other thing is, well, is the vaccine effective? And that's the one thing that's very surprising about the vaccine. They were like 94 to 95% effective. And a lot of people get that confused too. Like, well, I guess I got the vaccine, I can't get sick. That has not been studied yet, but it's in the process. Their main goal with this emergency use authorization was to see if you were vaccinated, did you get severe illness or die? So that the vaccines do their job from preventing severe illness or death. And that's 95% effective. Those are some impressive numbers. Yes, they did their job and they did it very well. And what you also think about, the other question is, well, what about the side effects? And I feel that a lot of times when we think about the side effects, we compare it to our healthy self. Say, oh, the side effects, you get symptoms like the flu, but I'm healthy now. I don't want the side effects like a flu. We're not comparing the COVID-19 virus to the vaccine side effects. COVID-19 virus, death, permanent lung scarring, inflammation of your blood vessels, possible strokes. We're not comparing it to that. We're comparing it to our normal self, right? So that might confuse people. But the normal effects from the vaccine that's been observed so far, it's more muscle aches. You may get a mild fever, headaches, and that's actually a good thing. It's your immune system responding. And that's the point of the vaccine, is to kind of, you get in there, you put the vaccine goes in there, and picture it was a suspicious criminal with the coat on. So the vaccine goes in there and say, hey, if you see anybody with this coat, you got to swarm on them and get on them right away. So the immune system listens to that. Okay. So if I see this coat, that's the bad guy, and I'm able to get in there before they can do any destruction. So that's what the vaccine does. So initially, the first dose, the immune system, okay, we got it. We see this white coat or anything like that, we're gonna go in there and get the virus. Then you get the second dose. The second dose is normally, for one is 3 weeks apart, the other one is like 4 weeks apart. You get the second dose, guess what? The immune system is saying, hey, they told us about this guy. They told us about this weird coat guy. They're swarming in again, except this time the immune system is a little revved up a little bit more. So you get the fever and the body aches. A lot of times the fever and the body aches and the headaches is actually your body responding. If a bacteria or a virus can go in, they'll go in and you'll be dead. That's what they want to do. They don't want to make noise. They're a burglar. They want to go in quietly, do their damage, and get out. But the body, when it heats up, the immune cells are able to attack better. They can move faster and do their job more efficiently. And it's alerting you. So yes, those are the type of side effects you have, but that's mainly the immune system acting. So I think I hit why was it able to develop so quickly?
You touched on other points that I was asking around that question.
Okay.
Yes, you were. One of the things that I've heard people say, and we got like 3 more questions, and we could be quick about them, so we can move on to allow Dr. McKent to have his to share his information. But okay. One of the things we have heard is people are asking, what is herd immunity? What exactly is it?
Nashawn, it's pretty much like you were saying. You're able to protect others who can't necessarily get the vaccine or have a healthier immune system to fight it off. A good way to put it is, if we put my grandmother in a circle of 10 people who's vaccinated, she's less likely to get that virus versus if I put her in a circle of 10 people who haven't been vaccinated, right? Herd immunity helps stop the spread of the disease, especially to the vulnerable population. Normally, they shoot for about, they really want up to 90 to 95%. I think some were saying at least get to 80% to kind of see how things are going. And that's pretty much the gist of herd immunity.
Okay, thank you for that. And another one that we've been hearing a lot of, especially in the news, is what is a variant? Because we're hearing about all this around variant. What exactly is it? Or should we even be concerned with that?
Okay, yes. So a variant is, let's see. So the virus uses a spike protein to enter the cell. So picture, let's see here. Here we go, I found one. Picture this. This is the spike protein, okay? With the spike protein, it attaches to our cell, it can enter, and then it can replicate into more cells. So instead of one, it's more than one, then those break out and it keeps repeating the process. So a variant, we found a vaccine that covers this protein so the protein can't enter the body. What a variant is, a spike protein has a different amino acids. What you would think about is, picture a Lego block, Legos all together to make one unit. When you have changes in those Lego blocks, it's called a variant. So any change in an amino acid can cause a different protein. Normally, those are harmless, but sometimes those variants give the virus superpowers, like make it more contagious than before, right? So do we have to be worried? There are some, I know particularly the UK strain and the South African strain, that those variants have made it where it's more contagious, but we're not seeing an increase in death. So that's good news. They are showing that people may be able to get affected, but you're not seeing those serious deaths or morbidity.
Okay, good deal. Well, I got one more question from my list of questions for you, and then I got two from Facebook that I want you to answer too. But my last question is, because I like to know when people telling me all this information about the vaccine and about COVID. My question to you, Dr. Patton, have you been vaccinated?
Yes, I have. Got to practice what I preach. Yeah, I got my last dose in January. My first time I got the vaccine, it had some pain in my arm that lasted for about 24 hours, and I haven't had any problems. The second time I got the vaccine, I had some pain in my arm again. It wasn't as bad, and a little pain in my fingertips, which was weird to me, but that went away. But the next day, I had a terrible left-sided headache, and it lasted for about 24 hours. And I was fatigued and down, but after that, it went away. I did take some Tylenol. I normally say if you cannot take medicine, it's best, because like I was saying before, you want that immune system fully revved, and you kind of practice how you play. So if you can avoid Tylenol or ibuprofen, I would say, yeah, don't do it. But if you have to choose between Tylenol and ibuprofen, I would go with Tylenol because it doesn't dull the immune system as much.
Okay. Yeah, thank you so much for that. And then these questions are from Facebook. I am 50 years old. When is the vaccine shot going to be available for us?
Okay. So they're currently going off different tiers. I think we're still at the 1B phase right now, the 70 and up. And that kind of depends on how they're gonna set up the release dates and the amount of vaccine, as both vaccines are currently a little more difficult because they have to be kept under real cold temperature. So that kind of creates a more of a shortage on it with the distribution, but they're currently working on that and more data is coming out. And they're also finding that there's significant still safety with using one vaccine and then spreading out instead of like 3 to 4 weeks, they can spread it out to 6 weeks. So that's saying that more people can get their first dose first before we consider doing the second dose. So it's a lot of variables in that. So we can't say exact date at this time, but it's still in the process.
Okay, thank you. Another question from Facebook is, if you're 90 years old and you want to take the vaccine in your malnutrition, should you take the vaccine?
So that's a great question. And I also want to say this is a great time to remind everyone that it's very important to talk to your primary care doctors and physicians who are more familiar with you. So that's a great question. I would say talk to your provider first and talk it out with them before you decide if this is a good fit or not.
Good question. Yeah, I mean, good response. Thank you for that. Because I've been telling people too, well, check with your doctor. You know, if you're uncertain, I can't tell you to do that. I'm surely not a medical professional, but check with your doctor. So thank you. Sharonda Ware from Question and Answer, her question is, if someone had the virus, do you still need the vaccine relating to active and passive immunity?
Okay, so another great question. You guys are having some great questions here. So now studies have shown that people who've been affected with the COVID vaccine have at least about a good strong 3 months of immunity. I mean, you're still protected with your antibodies. Now, they don't know how long that natural immunity is going to last, so they're still suggesting you get the vaccine. Now, if you've had the vaccine, they are suggesting to wait at least those 90 days of known protection before you get your vaccine.
Okay. Gina Davis from Question and Answer on the webinar is asking, I've been told to take the Dayquil or Theraflu after the second dose to ward it off any fever. Is this advisable?
So I would say that you want your immune system to be at its top, right? So if you can avoid it, try not to. You may have some discomfort, but if you can avoid it, try not to. But I always say go for a Tylenol first before any NSAID like Aleve or ibuprofen or naproxen. So normally, if you're gonna go for something and you know you have bad reactions to something in the past, I would say go for the Tylenol.
Okay. And this is our last question before we move on. Is it true, it's from Pamela Butler, is it true that once you contracted the virus and overcome it, you develop your own antibodies? So when would you need to take the vaccine?
Okay, so yes, you develop antibodies and everyone's a little bit different, but for the most part, you're going to develop antibodies and you can get the vaccine. They normally suggest up to after 90 days after you've been infected. That's just because up to those 90 days, you have those natural antibodies. They just don't know how long it'll last. So they still want you to get your vaccine regardless. And just to touch one more thing, if you have allergies, food allergies or drug allergies, it's still safe to get the vaccine. Just make sure you talk to your primary care doctor because normally once you get your vaccine, they're gonna have you sit around for 15 minutes. But if you have a known severe allergic reactions to other vaccines, they may want you to wait for about 30 minutes. But like I said, make sure you talk to your primary care first.
Okay. Wow. Well, thank you, Dr. Patton, for all of those, all that great information, then answering all the questions from the community, because these are questions that we just really don't know who to really ask. And we're hearing so much information. So we appreciate you giving us this information as it relates to the COVID-19 in the Black community. So thank you for that information. And I'm going to turn it over to Cindy Benedict, and she's going to do another introduction for us.
Thank you, Naishan. Thank you. It gives me great pleasure to introduce Dr. Kelly McCants. Dr. McCants and I have the pleasure of working alongside one another at Norton Healthcare. As you had mentioned earlier, I work for the Equity, Inclusion, and Belonging Department, and Dr. McCants is over the Health Equity Institute. As medical director of the Norton Heart and Vascular Institute Advanced Heart Failure and Recovery Program, and executive director of the Institute for Health Equity, a part of Norton Healthcare, Dr. McCants is passionate about serving patients facing difficult health challenges and addressing health disparities. Dr. McCants believes being able to serve is the greatest gift. He earned his medical degree from Meharry Medical College in Nashville, Tennessee, and completed his internship, residency, and fellowship at the University of Louisville. Growing up in Jacksonville, Florida, and Tuscaloosa, Alabama, Dr. McCants said he drew his inspiration from his mother and his older brother. He is the first physician and the fourth college graduate among 54 members of his extended family. As an African-American and a physician, Dr. McCants is deeply aware of structural racism and inequalities as he has experienced them personally. This helps him understand issues and concerns from a patient and provider perspective. So thank you very much, Dr. McCants, and you guys please help me welcome Dr. McCants as he discusses Healthy Hearts for African Americans and the Health Equity Institute at Norton Healthcare.
Thank you, Cindy, and hopefully you guys can hear me okay. First of all, Nation, thank you for all you do in bringing the CDC to the forefront. You know, Bates is close to my heart, and I really appreciate all that you do. Dr. Patton, thanks for your comments earlier. It really takes a team of providers to make sure that the community is aware, and Dr. Patton has done a phenomenal job in terms of how he delivers his message and really helping to put Norton Medical Group in the forefront. So as I talk over the next 15 minutes, I want to shift gears and really focus on heart disease in African American women. I think there's truly a challenge there, and although it's Healthy Heart Month, it's also the month of Valentine's Day, and we want to make sure that we highlight the importance of our women, not just this month, but throughout the year. And African American women are disproportionately affected by heart disease. And if Nation can start to share those slides, I'd like to move through them.
Yes, sir. Give me just a second. Can you all see my screens? Can you all see them?
Yeah, we can see them. If you can back up 2 slides, there you go. And so this is just the start slide. And I gave a similar presentation for Go Red for Women, American Heart Association. I think it's very important that we understand that cardiovascular disease is not just a man's disease. It's particularly when it relates to African American women, they are disproportionately affected by heart disease, and more specifically, heart failure. You can go to the next slide, Nation. So the real question is, why do Black women have more heart disease? And if you take one look at this interaction between this couple, these are actually my parents back in the late 70s, early 80s. And I think most of our Black women would say that the Black men are stressing us out. They're causing hypertension. And and they're giving us heart diseases. So I just wanted to show this picture, just to bring a little light to how stress can certainly cause hypertension and have an effect on heart disease. You can go to the next slide. So the real issue is that heart disease is not a male's disease. And when it comes to our African American women, particularly as we advance in age, women are disproportionately affected by congestive heart failure. And there's a direct link between hypertension and diabetes. And it really mirrors the health disparities outlined by Dr. Patton and how he very well pointed out that COVID-19 follows a destructive pathway of chronic disease. And so if you have hypertension, if you have diabetes, you're more likely to be at risk for heart failure, but COVID-19 as well. But I think the most important point is that when it comes to our women, we don't always present with the same symptoms as our male counterparts. And so as providers, we have to be a little bit more cautious when dealing with our women to make sure that when they come with an issue, that we don't just write it off as dizziness or stress or a bad day. It may be that there's some underlying difficulties going on that we need to pay a little closer attention to. Next slide. And I realize that, you know, sometimes graphs and statistics are a little bit hard to follow, but let me just make it easy for you. African Americans in general, men and women, lead every category as it relates to cardiovascular disease. And so you need not be able to negotiate this graph too much, but just realize that the highest bars are represented by African Americans. So that stroke on the left, myocardial infarction, which is a heart attack in the middle, congestive heart failure to follow. And the underlying risk factor for all of these is hypertension or high blood pressure. And so if there's a single message that you take away from the next 5 minutes, if you're an African American woman, please be serious about your blood pressure. You know, as young people, we don't always like to be on medicines. And, you know, you come into the physician's office and the blood pressure is high one time, low the next time, and you think everything is fine. But if you're African American and you have a blood pressure that's greater than 120/80, get on medicines and do the right thing, because I don't want to see you in my heart failure clinic. That's not what we want to do. Next slide. And what is heart failure? You know, I think a picture speaks 1,000 words. If you look on the left, this is what a normal heart looks like. It's shaped spherical like a football. But when you decide to get heart failure, that heart tends to enlarge, and the function of it, like any other muscle, is not adequate. And so you can very clearly see the difference between the muscle, which is pink, in these two different pictures. And this is what a heart looks like when you start to develop hypertension and heart failure. And so a lot of times it's, you know, we always, as providers, we give a very complicated definition of what heart failure is. There's a large range of symptoms that go along with it. But the basic message is the heart is not functioning like it should. And there are different degrees of heart failure, but you don't want your heart to go from a football to a basketball. Next slide. Very, very busy slide. And what we did at Norton Healthcare is look at all of our data over the last 3 years for patients that come in with a diagnosis of heart failure. And as Dr. Patton pointed out, from an African-American population in the city of Louisville, we make up anywhere from 17 to 20% of the population at its best. But when it comes to heart failure admissions, we make up almost 40% of heart failure admissions, particularly for those under the age of 40. Now, as we get older in age, greater than 75, we make up almost 60% of heart failure admissions. So there is something about being African American, there's something about being a female, and there's something about having hypertension that disproportionately affects our African Americans in the city of Louisville and across the United States. Next slide. So who's at risk? With 28 million folks in the United States diagnosed with heart failure, it is clear that African Americans are disproportionately affected, not just by the disease state itself, but when it comes to deaths, our Black males are disproportionately affected when compared to our white males. And certainly that trend continues for our females. Next slide. This is a pretty alarming statistic that I have highlighted in yellow. It says among Blacks aged 20 and older, 7% of men and 7.5% of women have heart disease. So these are in our 20-year-olds. And if you know anything about being young and being African American, very few 20-year-olds are going to a physician. And so if the trend already starts at 20, that means we need to start screening in our high schools and our colleges and in our YMCAs and in our churches, in areas where we can really have access to these young people, because this is way too early to start out with heart disease when it could be prevented by managing your blood pressure, having good food choices, and really better access to healthcare. Next slide. Another busy slide, but the most important point is that 64% of women who have heart disease either have no symptoms or no classic symptoms. And Nation, if you go on to the next slide, it'll pretty much highlight the difference between symptoms that men experience and symptoms that women experience. When someone is having a classic symptom of a heart attack, they tend to have left-sided chest pain, jaw pain, and radiates down their left arm. And that is classic right out of the textbook. But for women, it may be indigestion. It may just be mild shortness of breath. It may be, I just don't feel right today. And so as providers, we have to be really cautious when women come in a certain age group, particularly if they're African American, and they have non-specific symptoms. And so for you on the Zoom today, not trying to scare you, but don't always think that the symptoms that you're having are just stress or you had a bad day. If those symptoms are recurrent, you need to see your provider, because again, in women, cardiovascular diseases, it doesn't read the textbook. Next slide. And so if you have any two of these risk factors, if you have high blood pressure, if your cholesterol is off, if you have early diabetes or what we call impaired fasting glucose, or if you are gaining weight, your risk of heart attack or stroke has increased by 117%. And so when we start thinking about what we can do, we have to be able to exercise. When you exercise at least 30 minutes 5 times a week, your blood pressure is controlled. And once you get beyond that 30 minutes, you actually start to lose weight. And we understand that with every pound of weight loss, the blood pressure decreases by 2 to 4 points. And so don't underestimate the power of simple things that you do on a daily basis to lower your risk of cardiovascular disease. Next slide. Here's something that I thought was extremely important. And, the challenges that we have experienced over the last year as a society, particularly as African Americans, is significant. Well, this is a study that says race-conscious Blacks have significantly higher blood pressure than those that are not racially conscious. And I can tell you that there's not an African American in this country, at least over the past year, that has not had to address or deal with racism. See, when you're dealing with the stress of responding to race and systemic racism, your cortisol levels, which is a hormone, a stress hormone, continues to rise. And so there are many studies that show that just from the simple having to address racism or being in a situation to where race is an issue, that your blood pressure can respond to that. And I think we probably need to check Cindy's blood pressure, because she deals with this on a day-to-day basis. But this is a true phenomenon. And I think what we'll see over the next few years is that there'll be a lot of research related to race and blood pressure, just because of what the challenges have been over the last year or two. Next slide. So I'll go through this very quickly. We talked about what to do for a healthier heart, eating the right things in terms of diets that are not high in salt, being active, watching your blood sugar, making sure that you understand your numbers as far as your cholesterol and your blood pressure. And of course, there should be nobody on this particular Zoom who is smoking. But that's a easy one. Next slide. So here's my why. I am surrounded in my house by Black women that I love and care for, and so when anytime I get an opportunity to address hypertension in the African American community, I make sure that I give a message to women. In many scenarios, women are the head of the household, and if we don't protect the heads of the households, then what happens to the rest of the house? You can go to the next slide. Now we're going to shift gears for a little bit. Dr. Patton actually brought up some disparities as it relates to socioeconomic status. And in the city of Louisville, where you live affects your life expectancy and your health. There is a clear divide in terms of your life expectancy based on if you live on the west side of 9th Street versus the east side. And the same is true for many of our members that are in the Smoketown community. Next slide. And so if you live in the neighborhoods of California and Russell, statistics would say that you won't live beyond 69 years of age due to the disparities in that you deal with. But we can click again, Nation. But if you live on the east side, you gain almost 10 years just from moving almost five miles. And so your socioeconomic status in terms of where you live, what you have access to, what kind of resources you have, is the most powerful predictor of disease. And so we cannot discuss healthcare and disparities without talking about your socioeconomic status. Next slide. And so with the Institute for Health Equity, that's exactly what the Institute is designed to do, is to understand, deal with barriers to access, to make sure that it should not matter where you live in terms of your outcome. And so our only goal is to eliminate these barriers, to make sure that everybody has access, everybody's aware, and everybody has the opportunity to achieve their highest health. Next slide. And so there's been a lot in the media regarding what Norton Healthcare is doing as of late with the COVID vaccines and the clinics in the African-American churches. Those are just initiatives that are necessary. But Norton is going a lot deeper. We are investing about $40 million into the African-American community and vulnerable communities in Louisville over the next 2 to 3 years. And there's really a 5-step process that we're going to utilize to address these racial disparities. And as Cindy mentioned, Dr. Patton, Dr. Narcisse, Dr. Nodas, they will all collaborate with the Institute for Health Equity to make sure that as a village, we eliminate disparities in the city of Louisville. Next slide. When we talk about those 5 steps, we understand the investment that we made to the Urban League to make sure that there's access in terms of a learning center, access in terms of a sports complex in the West End. The development of the Institute for Health Equity is crucial into making sure that we make site-based investments into the African-American community. So you'll hear over the next year of specific locations or care centers that we will have geographically situated in communities of Russell, Portland, and California. We want to make sure that in Norton Healthcare, we look like our community. From a leadership perspective and throughout the organization, there's a push to make sure that we get more people of color into leadership roles. And then finally, we talked about the resource investment that we're going to make into the community. And so as we conclude, I think there may be one more slide left. I'm not sure, Nashan. Yeah. So as we conclude, I'll take a few questions, but know that Norton Healthcare and the Institute for Health Equity is committed to eliminate disparities as it relates to what these vulnerable populations are dealing with. And in the future, we do know that Bates will be a big partner with us, along with some of the other faith-based institutions in terms of what we're doing. Thank you
so much, Dr. McKenzie. Yes, we do have a few questions on here, but I got one of the first for you. Michael, you spoke of being able to get early detection and maybe have screenings at a younger age in the Black community. What type of screenings what's your suggestion on some things that Bates CDC and Norton's could possibly partner on to provide these screenings within our community?
You know, if it were up to me, I would figure out a simple mechanism to check everybody's blood pressure very frequently, and even the blood sugars. The fairs that we've done at Bates in the past have been very successful. And so when COVID is not an issue and we don't have to socially distance, we need to get back to that. But so partner with the CDC is going to be Bates CDC is going to be crucial as we move forward. And I'm sure Cindy has a bunch of ideas in her head in terms of where me and Dr. Patton need to be, and so we're going to follow Cindy's lead on that.
Okay, sounds good. Thank you. One of the questions is coming from Curl. Hey, Curl, with Norton's. Have heard older folks have less side effects from the second shot than those in their 30s and 40s. Does this mean they are mounting a lower immune response? And I don't know if that's for Dr. Patton or Dr. McKenzie, but it just got asked, so.
Sure. So I'll take a first stab at it, and if Dr. Patton wants to address this as well, that's fine. But so what we do know is that as we age, our immune system becomes less active. So I don't want to speak specifically to the vaccination, but I can give you an example for my older heart transplant patients. Once you cross the age of 70, you tend to need less in the way of immunosuppression to keep your heart from rejecting. So there's something about aging that changes your immune system as well. And I don't think there's any clear data in terms of how older populations respond to the vaccine in terms of less side effect, but there is a difference in the immune system when you start to age.
Okay. The next question is coming from Gina Davis, and her question is, I know some heart disease, I don't have my glasses on, please forgive me. I know some heart disease and cholesterol issues are congenital, hereditary. What about hypertension? Is that hereditary?
So hi, Gina, and thanks for your question. It is true that there are a lot of hereditary diseases that affect a lot of populations, but across the board, that is not the reason for most of African Americans. Most of ours is diet and lifestyle, things that we can actually impact. So I don't want anybody walking away from here saying that, oh, I got it from my mama, I got it from this. Nah, I'm not gonna let you slide with that one. So most of the statistics show that for us, it's lifestyle, which is good, because that's something that we can prevent. That's something that we can change. It just requires discipline and being aware and following a protocol that your provider gives you.
And Shanique, I don't know if we have any questions on Facebook, but I do have one more question myself, Dr. McKenzie. So I try my best to watch what I eat, and I feel that, our nutrition that we're putting in our body really helps us in a lot of different ways. And that's why at the CDC, one of the things we do is around healthy heart meals for the community. And we're seeing that people who are eating the healthy heart meals, maybe are coming back to us on a regular basis and they just look a little bit different. I'm saying they're not still feeling bad or may not have medical conditions, but it's something about them. I don't know if it's more energy. That could be exactly what it is, but the food that we're feeding them from our garden, and then a chef is preparing a healthy heart meals. It seems like it's, and I know we are what we eat, but it seems like the healthy meals are really helping in our community, the meals that we're serving out to the underserved people in our community. Do you think what we're eating helps with, that around heart disease and all that good stuff?
Absolutely. The other than exercise, the single most important thing that we can do is to put good things in our body. You know, I'm assuming that every January we still do the Daniel fast at Bates, and don't tell Pastor that I missed my time this past January. But for those on the call that engage in the Daniel fast, you know how good you feel at the end of it. And your weight, you normally lose 5 to 10 pounds. Your blood pressure normally drops. Your energy level is higher. Your mental clarity is different. And so that's a clear scientific experiment to show you what you put in your body matters. And so if at the CDC at Bates, if we're giving healthy meals and you're seeing it for people to come back, it is a testament. What you put in your body matters.
Good deal. And we have one last question. Someone raised their hand. So if you raise your hand, you can unmute. Or Shanika, can you help them to unmute so they can ask their question, please?
Hello, thank you. This has been very informative. My name is Shashra McCormick, and my question to you is, as you spoke about Black people and what's been going on in our country, of course I think about racial trauma, but we do also have a lot of our doctors that are guilty of being a part of that racial trauma. So how do we vet our doctors? How do we vet the people that are taking care of us to make sure that they're making the right choices regarding our health?
Wow. That's a very important question and observation. And I want to be thoughtful about how I respond to that, because it is a challenge that we deal with nationally. And Dr. Patton and I both can attest to that, being African-American providers. The statistics I gave the last time I spoke to Bates is that if you are a Black physician, you make up 5% of the physician workforce, which means you have a different level of accountability and responsibility in terms of connecting with your community and your patients. And so the challenge is there, and part of it is on us. And so from a vetting standpoint, I just want you to understand that if you're seeing an African-American provider, the hurdles that they had to jump through to get to that point by in itself is a form of vetting, because you can't be an African-American provider and achieve what you have without being accountable, without being responsible, and without doing the work of the community. Now, when it comes to non-African-American providers, that mistrust that Dr. Patton spoke about is real. And sometimes there are biases on both sides, right? Patients or folks in the community come in and they have biases. And then there's non-African-American providers that are not used to taking care of African-American patients. And so that's on both sides. But what we're doing at Norton Healthcare, and Cindy can attest to it with the division of EIB, is we're doing a lot of training. And a lot of that training is hands-on, is real-world situations to make sure providers are aware of their own biases. And so we're not going to have it fixed over the next month or the next year. but being aware and making people acknowledge that those biases exist is crucial. And so that's a long way around saying I understand it, and you have to vet it as a patient as best as you can. But our African American providers and our Hispanic providers and our providers of color, we are in tune, and so understand that.
Thank you, Shasha Ray, for asking that question. And we're going to conclude our whole entire session. I first want to say to Cindy, thank you so much. When I called and said, hey, I need Norton's to be able to help speak with the community, you said no worries at all, and you have always been committed with your work as it relates to the community. So I appreciate you answering to the call. Dr. McKence, we appreciate you so much. And the information you gave out was so important. I mean, so important for the community. And we need to hear those things from you. Even, I mean, just your whole PowerPoint. We needed to hear it from you, your PowerPoint. So thank you for taking time to continue to do what you do through Norton's. But the biggest thing I love about you, Dr. McKenzie, is you do it because you love the community. And you do it hands down, and that means a lot. And I just me working in the community nonstop every day and being able to pick up the call, a phone call, and say, hey, I need you out, and you all jump to the calls, that means a lot. And I say that publicly because when you need people to come and help the community, you want the people who are passionate about it. So I thank you, Dr. McKess, for being here and getting to the calls and being available the way that you have. And Dr. Patton, man, you gave us a whole class around COVID-19. I thought I knew a lot because I'm a big researcher, so I'm always researching, and I'm big on, I want data. Don't tell me what you think and feel. I want to know what's real. And you gave a lot of good information that I wasn't really prepared for or expecting. So I appreciate this. So I can only imagine everybody who is on the webinar, and then people who are, because we're streaming, it's going to be on YouTube and social media too platform. So just imagine all the persons that had the same questions, and you were able to come in and be very open, honest, and candid and answer those questions. We greatly appreciate you. Pastor Williams told me to tell you all, thank you, thank you, thank you. He is the board chair for Bates Community Development Corporation and also the pastor of Bates Memorial Baptist Church. And we're serving right in the most vulnerable community, the first African-American community in Louisville, Smoketown. And you could imagine, we right there with all the underserved and overlooked and all, we right there in the trenches with them every single day. Trying to help bring resources that they don't have, and they want the resource. They want to live, they want better health situation. They want to eat better foods. They want it. It's just not there. So we're trying our best to, be the advocate and be who we need to be to help the community. So I thank you all so much for taking time. Norton's Healthcare, you all truly you are who you say you are. Your mission, every time I go to one of the doctor's office, I see the mission, the vision, everything is always up, and I look at it. I'm like, I really like how every time I come in, it's visible, and you all really stand by that. So thank you all for doing what you do in our community, because Smoketown community, we really need what you all provide. We need this. So thank you all so much.
Well, thank you. If I can make one more comment. So, there are a lot of people that go into making sure that we're successful. Our Faith and Health Ministries, Carol and her team, they do a phenomenal job to make sure that we stay connected. Obviously Russ Cox, our CEO, and our leadership team for really standing behind this vision, the mission and values that you speak of. And we love Bates. We're committed to helping Bates, not just now, but in the future as well. And then special thanks to Cindy for always making sure we stay connected, and we really just just follow what she tells us to do.
Thank you, Dr. McCants. Thanks a lot. Thank you. Nashan, I do think that I heard you say something about a COVID vaccination site that will be available to the community. And that folks can also for all the COVID vaccination sites that Norton Healthcare will have as well.
Yes, that would be good. All right, well, we're going to go ahead and conclude our call for our Red Chucks Luncheon. This year it was virtual. Last year it was in person. And it was Kelly from your office, Dr. McKenzie, who came and spoke to us last year. I think her name is Kelly, I think.
Kimberly.
Yes, Vessel. Yeah, she was amazing who came and spoke last year. So we had to pivot and do things differently, but we still wanted to make sure we get this word out from you all and from Norton Healthcare, and everybody's been on tiptoe anticipation to hear it. So thank you all so much. And this won't be the last. Everybody who's watching now, we're going to be working on some more health initiatives. I'm going to be talking with Norton's and Cindy and working on some more initiatives and maybe webinars or whatever that looks like, just so we could all stay connected and be able to help each other. Thank you all so much. Enjoy the rest of your day.
You guys have a good day. Thank you.
Thank you.